Hello, good afternoon, and welcome to this week's NDARC webinar. My name is Sarah Farnbach. I'm a researcher here at NDARC, and I am today's host. Today, we're going to be hearing from Dr. Jack Freestone, who is a postdoc researcher at NCCRED and has come into research with a bang last year after finishing his PhD. Today, Jack's going to be talking about peer-led chemsex interventions for gay and bisexual men, which he completed while he was working at ACON, which many of you will know is a leading community organisation focused on health and wellbeing of LGBTQ plus people in New South Wales. So today, Jack has lined up an all-star panel, which is going to be really interesting to hear from. We've got, first up, Bo Justin-Zhao, who is a current coordinator for Chemsex and HIV leadership programs at ACON. We've also got Professor Adam Bourne, who is a visiting professorial fellow at the Kirby Institute and professor and director at the Australian Research Centre in Sex, Health and Society at La Trobe University. And finally, we've got also John Gabay, who is a CEO of AVIL, which is the Australian Injecting and Illicit Drug Users League. So it's going to be a really interesting panel. To maximise time with the panel, we're going to take questions through the Q&A function. We'll try to get through as many as we can, so please use that Q&A function as we go through the talk. Okay, before we start, I want to stop and just take a minute to show my respects and acknowledge the traditional custodians of the land from where we're all joining from today, which for me is from the Ngunnawal and Ngambri lands. We'd like to show our respect to elders past, present, emerging, and as well as extending a special welcome to any First Nations people joining us today. Okay, I'm going to get out of your way and invite Jack to please turn on his camera and mic, and we'll get started. Hey, Jack, how you going?
Good, thanks, Sarah.
All right, over to you.
Thank you so much, Sarah. And thank you to everyone for coming along to this webinar today and Doc for having me. As Sarah mentioned, we're going to be talking about exploring and implementing community-led chemsex interventions for gay and bisexual men who have sex with men. This was work that I complete as part of my PhD thesis, which was supervised by Krista Seafried, Mohammed Hamoud, Garrett Prestige, and Adam Bourne, and we're very grateful to have Adam on the panel with us today. Before I talk about the work in any more detail, I just want to give you some context. So it's probably not news to a lot of people on this call that in the mid-2010s, there was a lot of media, policy, and community attention on crystal methamphetamine. I think crystal methamphetamine and the people who use crystal methamphetamine were the subject of stigmatizing national campaigns and discourses. At the time, I was managing drug and alcohol programs at ACON, which, as Sarah mentioned, is a community health organisation for sexuality and gender diverse communities in New South Wales. And I think a little bit closer to home for me personally and professionally was growing community concern and a focus on crystal methamphetamine use among GBMSM in the context of sex, otherwise known as chemsex. In 2019, ACON made a submission to the Special Commission of Inquiry into the drug ICE in New South Wales. And in our submission, we really underline the importance of peer-led and community-led programs and services addressing crystal methamphetamine and chemsex specifically. And we did this in response to the data, in response to community concern, but also in recognition of the fact that ACON has a really long history of providing community and peer-led services across both sexual health and drug and alcohol use. So today, I'm using terminology of chemsex when I'm talking about this subject, but when we're working with community around this subject at ACON, we use a range of terms, including party and play, or P&P, or just partying. Essentially, by these terms, what we mean is usually the use of GHB or crystal methamphetamine for the explicit purpose of enhancing sex. Now, we're talking about GBMSM in today's presentation, but I want to acknowledge that we know that multiple populations combine a range of drugs with sex. However, in ACON's context, we also know that about 60% of our clients who come through our substance support counselling service are GBMSM who report that their primary drug of concern is crystal methamphetamine. Routinely conducted cross-sectional surveys in New South Wales also demonstrate a high prevalence of GHB and crystal methamphetamine use among GBMSM, about 11% for GHB and 8% for crystal methamphetamine. Both of those stats are within the past 6 months. And we know from the Fluxed survey that we estimate that over 85% of that use is for the express purpose of enhancing sex. So what is this experience of chemsex? There's a lot of research and media depiction around this phenomenon, which portrays the experience as one where sex is facilitated via online hookup apps and drugs are used to enhance sex, which is described as adventurous or inherently risky, where people engage with multiple partners over a long duration. Now, I think that kind of characterization of the experience is true for some people some of the time. However, before I started my PhD candidature, there was some really good research done by people at the Centre for Social Research and Health among Australian GBMSM using crystal methamphetamine. And that research really pointed out that people are using crystal in the context of sex in a range of different contexts and settings and relational dynamics, including in intimate and long-term monogamous relationships. And also that people have a range of harm reduction strategies that they use to extend their experiences of pleasure and mitigate their experience of risk. So I guess these ideas of chemsex, which overly prioritize or lean too heavily on these notions of adventure and risk, may well alienate some of the people that we really want to engage with our dialogues and service responses. I talk about harm reduction practices in the context of chemsex, but what are these? Now, this slide isn't an exhaustive list of harm reduction practices, but just some that come to mind and some that have been documented in the empirical research on chemsex relate to careful selection of settings for chemsex. So the choice of settings that enable for control of timing and dosing of drugs, the management of settings to remove hazards and risks, practices associated with gatekeeping, so choosing only to party with people who are known, trusted, or otherwise determined to be safe, practices as they relate to temporality. So this can include things like taking time to prepare for an occasion of chemsex, throughout a session, taking time to space out your dosing, taking time to recover, and considering your frequency or pattern of chemsex as well. There's been a lot of work done around chemsex and transmission risk as it relates to HIV. I think in an Australian context, we know that in the last 5 years or 10 years, uptake of pre-exposure prophylaxis and antiretroviral treatment for HIV has really mediated HIV risk in the context of chemsex. We also know that people who practice chemsex can be really good at communicating around drug use, priorities, and boundaries, but also communicating around sexual priorities and boundaries and limits as well. And the final thing I'll mention about harm reduction is that there's a lot of research conducted among LGBTQ plus communities which documents practices of care within networks around drug use. And it's really encouraging to see that these sort of cultures of care play out in chemsex spaces as well. So I think when we think about those harm reduction practices, it's not surprising then to realize that a lot of people who practice chemsex don't experience any harms at all, and in fact experience quite a lot of pleasure and maybe even some benefits. However, there are some associated harms, and the empirical research explores a number of these. So as I mentioned, it's been widely explored, the relationship between chemsex and HIV risk. And that risk has been mediated by pre-exposure prophylaxis and antiretroviral therapy. However, there are still some concerns around chemsex and the transmission of bacterial STIs like syphilis. There are some studies which document associations between chemsex and prevalence of hepatitis C. Obviously, chemsex carries risks for the transmission of hepatitis C via sexual and injection routes. There are a number of studies which document experiences around chemsex and acute harms such as overdose, acute mental health incidents, and sadly even death in recent years, there's been significant concerns associated with GHB overdose. The evidence base on chemsex and mental health conditions is quite mixed, with some studies denoting that people who practice chemsex have a more prevalent experience of depression and anxiety, while other studies note that those who practice chemsex are less likely to experience depression or anxiety, and attribute this to the fact that participation in chemsex often comes with participation in a social network, and there are benefits associated with that social connection for mental health. And finally, there's sexual well-being. And when I talk about sexual well-being, I'm not talking about sexually transmitted infections as much. I'm more talking about the notion of sexual satisfaction, experiences around sexual violence, and reliance on drugs for sex. Now, in terms of sexual violence and reliance on drugs for sex, there are several studies which document these experiences for people who practice chemsex. But on the flip side of that, there are also several studies which document the ways in which people can experience sexual gratification, exploration, and affirmation in a really positive way when they're engaging in chemsex too. So we can hold those two things next to each other. I think when we think about chemsex in a specific population, a specific culture of use, and a range of associated harms, it's unsurprising then that a number of researchers and other commentators have suggested that chemsex should be, met with appropriately inclusive and tailored interventions. However, there's very little applied or intervention-based research that's been conducted in the chemsex space. There's been quite a lot of empirical research, however, and I think there's a number of lessons or for practitioners about what effective chemsex interventions look like from that empirical research. And I've charted them on this slide in relation to a few key principles. And the first one there says incorporate harm reduction. Now, that's a recommendation which really recognizes that a lot of people who practice chemsex don't need to change their behaviors. And so for interventions to meet people where they're at, they really need to prioritize harm reduction. The second principle there, incorporate lived experience or be peer-led, really recognizes the fact that people who practice chemsex can experience real barriers to accessing services. And it's thought that peers, by virtue of their reciprocal lived experience, can mitigate some of those barriers to accessing services, but then in services facilitate rapid therapeutic rapport as well. And then finally, the third recommendation there acknowledges that chemsex is something which exists at an intersection of drug and alcohol use and mental health and sexual well-being. And it's, recommended then that interventions provide interdisciplinary and interinstitutional support. So we look at those recommendations, and then, at the outset of my PhD, look at what the evidence says. We saw that there was, recommendations around harm reduction, but scant evidence around community-based harm reduction practices relating to GHB overdose and sexual violence. And this is in a context where GHB was of increasing concern. There's recommendations to implement peer-led services, and we know that lots of peer-led services operate globally in the chemsex space, but very few of those have been documented in the literature. And third, there's a lot of evidence around barriers to service access, but less evidence around actual service experiences. So taking all that together and considering, I suppose, my employment at ACON, we asked the question, how may community-led interventions best support GBMSM to manage chemsex? And we addressed this question through three studies. The first three studies where we collected primary data, I should say. The first of those was a GHB harm reduction study. The second is the method study, where we developed and formatively evaluated a peer-led chemsex intervention. And the third was a study all about people's service experiences. I don't have enough time in the webinar today to talk about the GHB cultures, practices, and experiences study in detail. However, at a high level, this was a qualitative study engaging 31 LGBTQ plus people who'd recently used GHB, and we were looking to explore how these participants extended the benefits of GHB GHB use and mitigate risk, with a focus on GHB overdose and sexual violence, and a look towards, productive education priorities arising from that data. Again, unfortunately, I can't go into this in detail, but we published 3 papers from this study, which you're welcome to look into if you're interested. The first there was called Controlling for Pleasure and Risk, and that really looked at people's experiences around GHB overdose prevention. The second study, Understanding Attitudes and Practices, really looked at how people understood GHB overdose and responded in the event of witnessing an overdose among one of their peers. And the third study on that slide, Playing at the Edges, looked at how people negotiated sexual consent in the context of GHB use, and also how they understood and narrated experiences which were sexually distressing, and whether or not they labeled those experiences as sexually violent. I do invite you to check out those papers if you're interested. They're all open access. But also, we made this little short video summary, which is a much more efficient way of engaging with this data because it only goes for 5 minutes. So do check out that video if you're keen as well. We used the data from the GHB study to inform our method Chemsex peer-led intervention. And a lot of the learnings from that GHB study went into our method Chemsex harm reduction guide, which you can see pictured on this slide. And if anyone's interested, we have a number of physical copies of this resource at ACON, which I believe Bo Justin, who's talking later on the panel, will be able to mail out to you. Thank you, Bo Justin. So the method Chemsex harm reduction resource related to this study too, which was our development of a peer-led Chemsex service. So the peer-led Chemsex service method, it was devised in consultation with 16 people with lived experience of Chemsex, counsellors from ACON's substance support counselling team, and also a team of researchers. We based the method intervention on the stages of change theory, and we trained peer workers to work with clients to identify their goals and then provide a corresponding intervention. So there were 3 main intervention components: harm reduction education, motivational interviewing, and service navigation. Clients presenting to the service with no desire or no need to change behaviors around chemsex might have been supported with harm reduction education, whereas clients who maybe had been to some services previously and who were engaged in a process of trying to step back from or reduce their practice of chemsex might have been supported with, say, a motivational interviewing or a service navigation intervention. The intervention had 3 aims, which was to support people to reduce harms associated with chemsex, manage the frequency of chemsex, and access appropriate and affirming services. It was a talk-based intervention delivered one-on-one by 3 peers with living experience of chemsex. So that means a current practice rather than a historic practice of chemsex. And it was delivered in person and online. We supported peers to deliver the intervention with these interactive resources, which provided a guide for the conversations they had with their clients. And this work was adapted from some of the work that David Stewart had developed at 56 Dean Street Sexual Health Clinic in London. You can scan that QR code on top of that slide if you're interested in the kind of interactive tools that we used to guide our peer interventions. The method study, which existed alongside the method peer intervention, was a formative evaluation which really was designed to help us inform the replicability and adaptation of the intervention. The study period ran between May of 2022 and May of 2023. In the study, we interviewed 24 clients of the service. We also interviewed 3 peer workers and 6 other staff members who had a role in supporting the intervention. Interviews ran for about 60 to 90 minutes. And in addition to interview data, we also had peers collect field notes throughout the period of implementation. As I mentioned earlier, there's not been a whole lot of applied or intervention-based research work done in the Chemsex space. And although there's been a number of recommendations for peer-led services, few of them have been documented in the literature. And so we really frame the method intervention as a novel intervention without an evidence base around efficacy. So with that in mind, we evaluated its implementation against early stage implementation outcomes, acceptability, appropriateness, and feasibility. Acceptability was the perception among stakeholders of the intervention that it was agreeable, palatable, and satisfactory. Appropriateness was defined as the fit or relevance of the intervention and compatibility for ACON setting and for the intervention's clients. And the feasibility was defined as the extent to which the intervention could be carried out with regard for ACON's context, our resourcing, and our staffing capacity. We documented the intervention using a tidier checklist for complete intervention reporting, and we used an implementation research logic model, which was a tool that we used to map our intervention context, the intervention inputs, the strategies that supported implementation, the reasons why we thought those strategies would work, the intervention itself, and the evaluation outcomes. This is a very high-level visual demonstration of methods implementation research logic model. I use this sort of retrospectively at the stage of analysis to make sense of all the qualitative data that we collected around this intervention, and I found it a really useful framework to map what was going on in terms of intervention determinants, the strategies that we use to support the intervention, why those strategies would work, and then the narrative around our implementation outcomes, acceptability, appropriateness, and feasibility. In terms of the narrative around those implementation outcomes, I'm going to talk through that in some detail now. All in all, oh, no, I'm not. I'm actually going to talk to you about the participants before I get there. Sorry. So in the method study, we interviewed 24 participants from the community. The eligibility criteria for these participants was that they needed to be trans or non-binary people reporting sexualised crystal methamphetamine or GHB use within the previous 3 months and living in New South Wales. We also interviewed an additional 9 staff members who were peer workers, ACON counsellors, and also the method clinical supervisor. Some things I want to point out about these participant demographics here. One, we see in the ethnicity that our research sample was largely Caucasian. Now, that's not really all that reflective of the demographics of people who received the intervention. I would say that about half of the people who are coming through the method intervention are not Caucasian, are overseas born, or culturally and linguistically diverse. However, we didn't achieve really great research uptake among culturally and linguistically diverse participants, which I think is a real limitation of this data. The other thing I want to point out to you on this slide is that 18 out of the 24 people that we interviewed reported that they were currently dependent on crystal methamphetamine according to the severity of dependence scale. Now, the implication of this will become clearer when I talk through the findings. However, at a high level, I think it's important to sort of outline that when we first devised this method intervention, we thought about it as a brief intervention, predominantly providing some light harm reduction education for people who maybe didn't need a whole lot of intervention support. In actual fact, we found that we were engaging an entirely different group of people, a group of people who'd often been through services previously and who were engaged in a process of behavior change around crystal methamphetamine use and who, wanted ongoing peer support. So now I'm going to talk through the data on acceptability, feasibility, and appropriateness. I'd say overall, the intervention performed very well in terms of acceptability. Our clients largely reported that the intervention provided them potentially their first ever opportunity to have an open and honest conversation with someone about their practice of chemsex. People suggested they hadn't been able to talk to services about chemsex previously, they hadn't been able to talk to their friends, and they hadn't been able to talk to fellow people who practice chemsex, particularly around processes of trying to change your relationship to chemsex or step away from the practice or take a break. The acceptability data is sort of nicely captured here by Trent, who says, I've been HIV positive since 1984, and I've also had a couple of bouts of hepatitis C, and there's a huge stigma attached to that. So the taboo of talking openly about chem use and the stigma against that, you just shut down. So to talk to a peer, that safe place to talk just helps self-reflection and getting your head around it. I think Trent's experience is indicative of a number of our clients who reflected that their experience of multiple stigmas associated with HIV status, with age, with their drug use, had prevented them from accessing care and support previously, and they really appreciated the space that the method peer intervention afforded. I was really encouraged to see also in the data that the intervention was acceptable to the peer workers. The peer workers reported that they received a number of benefits from engaging around the intervention. One of those obviously being employment and all the benefits that come with that, but another being really, you know, a sense of purpose. And this quote from Kevin, I think, speaks to that quite nicely, where Kevin says, I think it's facilitated my recovery. And by my recovery, I don't mean I'm completely drug-free these days. It gave me a strong sense of purpose. It required me to be responsible and accountable daily. And I think knowing that my organization is on my side and my lived experience is valued to whatever degree, that has really helped me to take ownership of my drug use, take ownership of my trauma, my all kinds of experiences in the past, and just move on. The final piece of acceptability data I want to share with you comes from our allied clinicians and counsellors. So we delivered this intervention alongside our ACON substance support counselling team, and our counsellors at ACON were extremely helpful. They provided training to our peer workers, they provided ongoing coaching, they provided some debriefing as well. But when we first started delivering this intervention, we actually had a really hard time attracting clients to the service, and we weren't getting many referrals from the substance support counselling program either. And we had anticipated that we would be getting quite a few referrals from our substance support counselling program. We drilled into this with our substance support counsellors, and what we heard was that, you know, there was this perception that the peer services existed over in one spot and the clinical service existed over in the other spot, and the two shouldn't necessarily meet. There was also concern around, you know, the training and capacity of peer workers to deal with some of the more, I guess, challenging circumstances that clients might be faced with. And there was a sense that there wasn't a whole lot of transparency around what the intervention entailed. And this is reflected by Alex, who said, that's probably where some of the tension is as well. It's a bit of a mystery for us, you know, we don't have a clear sense of what that conversation is that a peer has with a client. So this data really highlighted to us that we needed to do a lot of work on that kind of clinician and peer integration piece. And that's something that we've done since this formative evaluation. The peers and the clinicians at ACON now work alongside each other a lot better, and those sort of between service referrals are flowing a lot nicer. There was quite a lot of data on appropriateness that I'm going to speak through in quite a high level way now, but essentially I've broken it off into 3 different sections: content, peer identity, and the brief intervention protocol. In terms of content, we saw from peers themselves in their field notes that they were delivering all different components of the intervention, so harm reduction, service navigation, and motivational interviewing, and that participants really valued each of these components as well. In terms of the peer identity, participants in the research reported that they really valued working alongside a peer with living rather than lived experience. So it's a current practice of Chemsex. I think that there was a sense that working with a peer with living experience kind of leveled the playing field in a way and aided that sense of reciprocity. It's important for me to note as well that the service wasn't promoted as a sort of abstinence-oriented service. The other thing which we learnt about peer identity was that our older participants really didn't want to work alongside younger peers. And the reasons for that were many. Older participants sort of had this feeling that they had a wealth of life experience. They'd been through HIV in the 80s and the 90s. They'd lost partners. They'd been in marriages. And then, in their current life, they'd experienced ageism in the kind of gay, social, and sexual landscape. And I guess this wealth of experience felt that they felt that, a younger peer worker wouldn't be well matched to talk through those experiences. And then also that, those experiences of ageism presented some barriers as well. So luckily we had an older peer worker on staff as part of the method team, and we did some demographic or identity matching around that. In terms of the final thing on appropriateness was that overwhelmingly people rejected the brief intervention protocol for method. So at the outset of method, we devised it as just a one-time service. And I think that we did that because we had a degree of anxiety about how we managed the scope and boundaries around the intervention. It was a new frontier of peer work for us, not only in the subterranean of Chemsex, but then also it being a one-on-one peer service was new for us. And so we thought to mitigate some potential risks around that, what we would do was control the scope of the intervention with a brief intervention protocol, provide peers quite a lot of training, supervision, and support, and also provide peers guidance in terms of materials that could, protocolize interventions. Other than the peer supervision, training, and support, I would say that the efforts to kind of curtail the scope of the intervention didn't really work and was broadly rejected by our clients. And this is reflected by Thomas, who said, I was a little bit disappointed that we didn't have a follow-up meeting. I thought, wow, he's just done. He's just ticked the box and I'm out. It's like I was auditioning for attention. And then I asked Thomas, it would have been good for you if it had been said, do you want to come back and see me in a couple of weeks? To which Thomas replied, no, not do you want to, but I'd like to see you. I think it might make a difference. I guess what this quote indicates to me is that while a lot of people said that when they went and saw a peer worker, they experienced this very meaningful, valuable conversation with reciprocity and meaningful sharing, which was a very unique and powerful experience. But the benefit of that experience was curtailed by the fact that they were then told they could only see that peer worker once and would have to come back to the service to see a different peer worker. It just didn't work. And I think that one-time intervention protocol exacerbated some participants' previous experiences around kind of social and sexual rejection, which is important for us to consider when we think about the fact that this was a peer intervention that was being delivered in relation to a gay social and sexual landscape. I think we needed to be a little bit more cognizant of some of those sensitivities. We clocked this pretty early on in our intervention, in our initial implementation, and we revised the protocol and allowed peers to work with people over multiple sessions. The final thing I'll talk to in terms of the peer intervention is around feasibility. And the feasibility of this intervention was really aided by the fact that we received research funding. The research funding offered us the opportunity to recruit a team of peers, which was regarded as extremely important because peers said they got a lot out of having many opportunities to debrief with each other. And this is reflected from this quote from Billy, who was initially managing the method service. And he said, you're playing in a space that can be very challenging and complex in many ways. Organizations need to care for their staff in this space, overcare for their peers, give them a buddy system, give them multiple contacts. I can see things going really wrong if an organization tried to develop something like this and let that peer just kind of go on, maybe on their own with one contact. The other thing which supported the feasibility of this intervention, I think, was the community trust in ACON. A lot of people coming through the service said that they felt comfortable to do so because they knew of ACON, had potentially engaged with ACON services previously. And the other thing which I think facilitated feasibility in this context was the fact that it was delivered alongside a team of clinicians. You know, as much as we tried to do some work to make sure the intervention was appropriate for clients before they came on through, we did find in some circumstances that peers found themselves having to respond to kind of crisis situations, and having clinicians on site to support with those crisis situations was really key. And having clinicians on site to support with kind of ongoing training and capacity building was really key. But as I mentioned before, we needed to do that work around that peer and clinician integration piece. So based on some of this data that I've just presented, we made some adaptations to the method intervention. First up, we altered the protocol of the intervention to enable peers to work with people one-to-one over a longer time frame. Second, we co-located our method peer workers alongside ACON's client services team, and that really helped with that peer and clinician integration piece. And the third thing which helped with that peer and clinician integration piece was that we devised and commenced a peer and counsellor facilitated group program. And that also really supported our clients to access ongoing support after the one-to-one intervention. And that group program is still running today and has been really successful with good uptake. So we've received some really nice feedback on this body of work in general, but this quote stands out to me, and I just highlighted it because it makes you feel good about putting in this amount of work and seeing that it's being well received. And this particular client said, "This has been such a great support. It's given me a great set of tools for my toolbox to allow me to grow and to allow me to become the best version of myself. I thought I'd be judged, but it's been beautiful to be in a room of people who've been in the same shoes and have all the support of people who've gone through it. Has been life-changing." I don't think I'm going to talk to the last study just because I'm keeping my eye on the time, and I'm mindful that we have a panel of experts in the field joining us on the webinar today. Oh, sorry, I'll just go back and show you. If anyone's interested in the last study that's arising from this piece of work, we did an analysis of people who are coming through the method service, their prior experiences of services. And this has been published in Drug and Alcohol Review. If you're interested in that paper around service experiences, please go take a look. I think I'm going to leave it there. But let me just get to my acknowledgement slide before we see the panel. I just want to thank the 64 people who participated in this research and supplied data to us. I want to thank the method team who delivered the intervention, with a particular thanks to Bo Justin, to my PhD supervisors, to the chief investigators who sat around the studies that I'm talking about today, to the organizational partners who are all listed on that slide, and particularly thank you to ACON for supporting this work, to NCCRED for supporting this work, and to the Kirby Institute. Thank you so much. I'm gonna stop talking there so that we have some time for a bit of a panel discussion.
Thanks, Jack. That was great. What a nice talk. I've got lots of notes here, but I agree we should get on with our panel. So I'm going to invite our panelists to please turn on their cameras and their microphones. I mean, I've got some thoughts, but I'm actually just not going to hog the floor here. So I'm going to see if any of our panelists would like to start us off by just giving a 1-minute reflection or thought or comment on the information that Jack's presented today. Who wants to go first? John, you're on.
Yeah, I'm happy to go first. Congratulations, Jack. Such an amazing presentation, and this project is incredible. I think really highlights the importance of peer leadership within this process, but also how we need to tackle stigma and discrimination in many ways by using harm reduction and peer support. So I'm going to stop here, but again, congratulations on this presentation, but on the project as a whole as well.
Thanks, John.
It was brilliant, Jack. I always love hearing you speak. Now, obviously, I have a vested interest in having been one of your PhD supervisors, and so I don't want to appear a groupie here by saying this. But I really do genuinely believe that what you've been doing is exactly what is needed and we need much more of in the chemsex research field. We've spent 10 years or more examining chemsex. We've looked at the prevalence of it, patterns associated with it, harms associated with it. We've thought about it in terms of pleasures. We've looked at the cultural and social drivers of it. We've looked at cultural practices and meanings. We've looked at the mechanisms of drug administration. But we've done considerably less of this really robust, really evidence-based intervention design and evaluation. And I think the fact that it's drawing on expertise that exists within peer communities of people who use drugs, I think is what makes it especially valuable. I think it is via peers that we're going to bring about changes in practices that ensure people are doing, where they are using drugs, they're doing so safely and reducing harm as much as is possibly the case. So I just wanted to reflect that I thought it was a great idea when you started on this road 4 years ago. I still think it's an excellent idea. And I can still probably only count on one hand the number of similar evidence-based evaluated interventions that exist on this topic anywhere in the world. So it really is extremely valuable.
Thank you, Adam. Thank you, John.
I just want to quickly say, I guess I just want to quickly express my gratitude to Jack for being on my side during the implementation and design of the method program. It's been, I guess, 6 years almost since we first started from scratch. And every time we get any sort of feedback from community, that just kind of take me back to the very start, and I can't think of anyone else to do this. So yeah, well done on your PhD.
Oh, thank you, Bo Justin. The pleasure has been all mine.
Excellent. Thank you, everyone. I mean, I couldn't agree more. Like the some of these findings I found myself nodding along with and thinking more broadly, like this is relevant for the communities that you've been talking about today, but also just more generally in the AOD space, but also just more generally with other people as well, you know, around a range of health issues. The idea that you want to see the same person when you go back to services repeatedly just seems like a really good idea generally. So yeah, I think you've done some really great impactful work. Thanks, Jack and team. Okay, I'm going to jump into some questions. So we've got a question here from Leonardo, who's saying he's actually also studying chemsex in Mexico, and he found that this practice has an indirect association with depression mediated by social support. And so I just wanted to open that up to the panel and Jack to have a bit of a think about.
Yeah, it's a really good point, and welcome from Mexico. That's exciting that you're zooming in all the way to Australia here. I'm aware of a few studies which have actually documented this sort of inverse association. You know, often we might think that this is a practice which is associated with poor mental health, depression, and anxiety. But there's been at least 2 studies that I can think of which document this inverse association. And one of those studies has been in the context of people living with HIV in Australia, and I think it was a study actually done by Adam's group. I think it's the HIV Futures study, which shows that HIV positive GBMSM who practice chemsex actually report greater social support and therefore better mental health outcomes. So I think it's a testament to the fact that these are spaces where really meaningful connections can happen, and a challenge to that notion that drug use is always about risk and deficit. It can actually be about benefit and pleasure as well. Did you have anyone else wanted to say on that?
Maybe I can just add as well, but first, I absolutely agree. I think we have to look into how drug use and chemsex can benefit people as well within those social contexts. And I would like to discuss a bit more about the peer support aspect. I think there is something there that is key just in general for the well-being when it comes to harm reduction and chemsex. It just makes such a difference when, like, if you do need support, you're able to access someone that understands your experiences, and that the stigma is reduced by having someone that has that understanding. So I agree. I think peer support can make a big difference for people, but I also agree with Jack that we shouldn't just look at it through the lens of like risk risk and possible kind of risk factor, but also people wanting to connect and wanting to have pleasure and experience something amazing.
Beautiful. Well done. Thanks, guys. Okay, I'm going to move on to the next question now. I mean, this question was sort of answered by you beautifully, Jack, in the talk. Just wondering about the cohort that you included into the study, that they were mostly, 40 to 49 and 60 plus, and maybe that provided some of that context for where you found some of those findings. But did you want to have any reflections on that, on the age of the cohort and those? And I thought that was interesting, the finding about how needs changed over the lifespan. Did you have any thoughts or comments on that, anyone?
Yeah, look, but Justin, I don't want to put you on the spot here, but I wondered if maybe if you want to talk about your experience in delivering the service in terms of how we're thinking about matching peers with their clients
Sure.
based on any identity characteristics and your considerations around that.
Yeah. Matching clients with the right peer can be really tricky, and we don't really just follow the matching an older person with an older person or a migrant with another migrant kind of way. Usually we look at life experience as a whole. And yeah, we keep getting surprised by how well some peers can work with, certain type of clients. In this case, I guess in the case of age gap, I think sometimes that can be a really beneficial thing for both the clients and the peer to actually listen to a much older person or much younger person's perspective when it comes to drug use and sex and, I guess, GBMSM identities. If it's okay, I may also answer the next question in terms of busy periods, because I think that would come to me anyway. We are not as busy as people think during Mardi Gras. Usually we're busy after Mardi Gras when people have had their parties and want to, I guess, reconsider their life choices. We also get an influx of clients in the months before Mardi Gras, where people really try to kind of make decisions around whether I should party, how big should I do, like, should I party this time? And peers are really good at, I guess, planning out those party seasons with the clients in terms of like what is sustainable for you, how can we minimize the harm, not just with drug use, but financial and social harms. So yeah, we don't really have I guess a peak season, but if I have to pick one, I would say before Christmas and New Year is our peak season because everyone's kind of freaking out. The year has passed. Yeah, I'll leave it there.
Can I just jump in? Thank you, Justin, on that thing about busy periods as well. I just realized that Sarah and from the comment, I didn't touch on that question about the life course in relation to Chemsex. And I just, on reflection, one thing that stands out to me is that we did see, and we do see, a cohort of quite young people coming through the intervention, often international students who have a particular set of information and support needs as it relates to Chemsex. And then a lot of our older clients coming through the service often narrate their kind of transition into Chemsex after significant life experiences like the breakup of a long-term relationship or coming out as gay for the first time and entering community. And sort of, I guess, what stands out to me about both those experiences is that Chemsex was often narrated as a pathway through which to connect to other people in the community. So it's like I arrive in Sydney for the first time as an international student, and then somehow I find myself doing Chemsex as my way to kind of establish social connection, or it's that I've come out as gay, or I leave my relationship and then I establish my connection, and this was my inroad. Obviously sometimes people's experience of that can can lead them to a point where they might need some support. So while there can be really beneficial social connections, there can also be experiences where people need some support, then renegotiating or re-navigating that and finding out what other communities or touch points are available as well.
Yeah, that's really interesting, isn't it? And yeah, all these different contexts under which people are coming into the service. I wonder, John, if you've got any reflections from your perspective at Able about any of the work that you're doing around harm reduction and chemsex.
Yes, multiple reflections, but we're currently working on a peer work framework. It was one of the element in your presentation, Jack, on the safety for peer workers, especially in non-peer organization or like for a specific program with not a lot of support. So we are currently working on a peer work framework, a national one, that would have a lot of information to support employers and employees as peer workers of peer workers. So that's one aspect of it. The other one is we're currently developing a national, if not regional or international, resource hub that would be from the lens of chemsex harm reduction and have a lot of information that is, by peers for peers, which is really exciting. And we are also currently working on a pilot project nationally to provide safe sex kits, but that include harm reduction products or resources for people that engage in chemsex or in the sexualized use of illicit drugs. So multiple things happening. I think it is a pretty trendy subject. But we're also doing a lot of work with our partners in Asia and in other parts of the world that have a big community of people that engage in chemsex. But I think it's important to note as well from Abel's point of view, because we represent all people who use drugs, to also discuss people that are cisgender or people that are that can also use drugs in a sexualized context and may not know as much as some of our LGBTQ peers. So we want to make sure that we have a really rounded approach of that as well, that is focused on chemsex, but also on other people that may want to explore this avenue, and so that they can do so in a safe way. And we also have a resource on ODTP, so opioid dependence treatment, on the AVOL website that has been developed by peers at AVOL and is incredible and very comprehensive. As it was mentioned by Jack, that sometimes people can struggle with dependence and want more information. So there's a bit more information on the AVOL website about that. But for us, it's really important to include chemsex within the harm reduction kind of whole of the whole programs, I guess, of harm reduction that needs to happen in Australia. I think we really need to have a strong stance on national harm reduction for chemsex to ensure that people are safe, people are supported, and not left behind due to stigma and discrimination, especially considering that criminalization fuels stigma and discrimination. So people that are engaging in chemsex or in the sexualized use of illicit drugs are always at risk of repercussions, and especially for migrants. So I think that's to keep in mind. But there's a lot of work to tackle in this area. AVOL is really engaged in this process to develop more resources and programs with our network and partners as well.
Oh, beautiful. That's such a great point. I just want to pick up on this idea about the resources that are available. And it's a question that Joel's just popped into the Q&A. He's wondering, are there any resources or interventions available that target specific factors, for example, around the glorification of chemsex or the pleasure associated with it? So, I mean, I'm not sure. This is kind of all of your field. So I'm going to just hand this over to whoever turns their mic off first and starts talking.
I can talk about it briefly and leave some space for others as well. It's a really interesting point, and I think one thing that the terminology of glorification is interesting. One thing that I that we think about in relation to method, and some work that we sometimes do with our clients is around this notion of self-expectations of what it means to be a gay man, and then self-expectations around participation in kind of sexual cultures. You know, this notion that to be a gay man, what you do is you have lots of sex and you have lots of drugs, and that's how I perform my identity. That's something that comes up quite a lot in our consults with clients, and we do quite a lot of work with people around challenging that and helping people to connect with other elements of their life and authenticity as well. I don't know, Bo Justin, if you want to speak any more to that piece, or if you think I've kind of captured that. No? I don't know if anyone has any other ideas around that, John.
I think it's important to mention as well that, you know, again, within a criminalized setting, and with people, LGBTQ people that, you know, are affected by stigma and discrimination, it does affect how people perceive themselves and how they navigate the world. So I think it's important to start talking about decrim as well, decriminalization, and peer support that really, again, bridges or reduces the barriers for stigma and discrimination to, yeah,
hot topics at the moment.
I was just going to.
Oh, sorry. Yeah, I was just going to invite you.
Oh yeah, no, I was just going to echo some of Jack's points and point to one specific intervention. I mean, I think Jack's absolutely right. I think sometimes gay men, particularly young gay men, some people, and I think we see it also with people who come out later in life. This sense that to be a good gay man, I'm supposed to have lots of sex. I'm supposed to have lots of sex partners. I'm supposed to use drugs with my sex partners. And people can sometimes find themselves enmeshed within social networks where some of these norms can feel quite pervasive. And just one intervention that I'm aware of that where a big part of it is trying to tackle it is the Rewired program that happens at Thorn Harbour Health. That's a really, really big part of kind of deconstructing some assumptions that people have kind of brought consciously or unconsciously into this group therapeutic space around what it means to be a gay man and how they've come to think about how, you know, why they're using drugs. Absolutely, from a harm reduction and a sex positive perspective, saying, you know, if you want to use drugs, that's absolutely fantastic. Just, you know, think about why you're using them and how they're impacting your life, how they're bringing about pleasure, and what are some of the things you can be doing to help manage or mitigate harm if that's occurring to you. I mean, it's not, I can't point you to a written resource, but certainly I think that program is a good example of how they're trying to do that, address this kind of issue.
Wouldn't you say, Adam, as well, that there's some other spaces as well where it can see as like being a good gay man is not to do drug, and so that stigma would be there as well, that doing drug is bad and that injecting drug use is looked down upon. So I think there's those two spaces as well that we need to be aware of, because people have the right to use drugs if that's the way they navigate the world, and we want to make sure that they are supported in doing so, and that the stigma aspect, because that's the negative policies, but also the stigma really impacts people's health and well-being.
I couldn't agree with you more, John, honestly. And it's remarkable how the gay community can hold both of these things simultaneously, I think, at times. And I think stigma associated with chemsex has been incredibly destructive in lots of parts of the world. I think Australia's done a good job to tackle that quite proactively, but by no means perfectly, and a lot more to do in that regard.
It's really interesting. I've learned so much. Now, we're actually at time. We've got a bunch of questions, and I always feel bad when we haven't got through them. I've got the questions. I'm going to send them to the speakers. If you have burning questions, and I'm terribly sorry we haven't got through them all, I always feel like we need an extra half an hour for these panel discussions. Please do get in contact with our speakers. I'm sure they'll be happy to continue the conversation with you or answer any of these really great and quite specific questions that we've got online. But I will have to close, I'm afraid. I just want to really thank our panelists and Jack for joining us today. It's been a really fun webinar to be part of, really interesting conversations and some great insights. So thanks everyone for taking the time out. Now, just a quick Bit of promotion for our next couple of webinars. We're actually having a week off next week, so you can have your Thursday afternoons back. And then the following week, we've got NDARC's own Professor John Weatherburn presenting some information on the New South Wales Drug Court and the impact of it on health and social functioning that he's been doing recently. So we'll look forward to seeing you in 2 weeks' time. But for now, I'm going to close. Thanks everyone for joining us, and we'll see you then.
Thank you so much.
Thanks.